Hello class. I'm going to continue talking about assessment of the respiratory system. I want to kind of talk a little bit more in detail about some of the assessment methods, which would include some of your patient history. This is really important when we want to look at the history of maybe why a patient has acquired certain signs and symptoms that they may have a respiratory problem. It could help us diagnose whether or not this is an acute or a chronic problem. And then possibly with finding out detailed health history, we might further see the physician order further diagnostics to conclude and be able to make that final diagnosis. Obviously, where a person lives, their home, their community, their workplace, just the environment they live in is extremely important because many times when people live in areas of high pollution or factories, these are things that could actually cause lung disease, or if a person has already been diagnosed with lung disease, could worsen that person's lung disease. So this might be very important to the physician as well as to the nurse to know exactly his precise environment in which he works and in which he has his home. Occupational lung disease is really very significant. Inhalation of certain substances including dust, toxic lung injury, coal miners, even people who work as stonemasons, and then again working around the dangerous substance of asbestos. We know a lot more about occupational hazards with these certain substances that we know now through research and through presentation of how people develop these chronic diseases, and even some of them that have become fatal for some people, where it has actually caused their death. We're more apt to advise people to wear masks and protective garments to prevent inhalation in the respiratory system from these particular irritants. And I think a lot of things like OSHA have created standards in the workplace when people work around these particular substances to protect the public from acquiring certain respiratory problems that could eventually lead to disability as well as their death. We don't think about it, but in a person's home, we like to kind of know what type of heating they use, whether or not they have a gas heater, a wood-burning stove, even a fireplace, kerosene heaters. Maybe the person has been exposed to certain irritants as to what particular product they're burning to keep their house warm. Think about people that have hobbies. Years ago, especially when I was a child, airplane glue was something that we were very careful to be around, and our parents would tell us not to inhale it. But some of the substances used to create different, projects really can be hazardous to the respiratory system. Even people who not only build model airplanes or any type of models, we can also talk about people that like to refinish furniture. There's a lot of chemicals and varnishes and products used to strip wood and then to finally refinish the wood piece. Think about women or men who work in spas that do pedicures and manicures. There's a lot of chemicals in those spas, especially when women have acrylic nails done. If you ever walk in there, wow, it can really make you quite taken back by the strong aroma of some of those chemicals that they use. And if you notice, some of the workers do wear masks when they're doing someone's nails, so they aren't inhaling those irritants all day at their job when they're working on people. So those things are really important. And some of the products that people use in their occupations, usually do have some kind of warning about wearing protective mask to prevent inhalation, and that's mostly where these people acquire the problems, is due to inhalation. Think about just a person's respiratory history regarding smoking. We kind of figure out, how much they've smoked by how many packs per day times the number of years that they've been smoking. Are people truthful? We're not always sure about that. And the problem with smoking is it really does cause so many problems to many other systems in the body, not just directly to the respiratory system. It interferes with ciliary action in the lungs, and it really does increase bronchial secretions, causing your patient or a person to develop more inflammation and a hyperplasia of the mucous membranes. And it also decreases the production of surfactant, and it also impairs that bronchial drainage. So there's a lot of things that we think about when a person smokes, because you can kind of picture exactly what pathology is occurring in a patient's lungs. And we won't even get into the effect it has on the cardiovascular system. We'll talk about that later on when we talk about the cardiac system. Maybe people want to quit smoking, and that may be something we can assist our patients, providing them sources of support to be able to quit all kinds of nicotine patches and gum and things like that. Those are sources of ways in which people really want to quit, and in ways that they can quit, because as we know, a smoker who has smoked quite a few years, it has become an addiction, and it's very hard just to quit cold turkey. So we as nurses can educate and provide sources of ways in which a patient can obtain and acquire help to be able to quit smoking. And remember, smoking, as I mentioned, the various effects it has on the respiratory system. It basically, the bottom line is it, really can change at varying degrees of airway obstruction. And with men, you see more of a rapid decline in pulmonary function than you do in men who don't smoke. So that's something really important to think about, because right away, when you are aware that a person, particularly a man, has been a smoker, especially when we care for them in the hospital in their 50s, it puts them at risk for a lot of things, not only cardiovascular disease, not only COPD, but men who smoke are also at risk for bladder cancer. So there's also some other high incidence of other diseases that these people can acquire with smoking. Think about a person's drug use. We only think about illicit drugs, street drugs, but that's not necessarily what this encompasses. It also refers to prescribed drugs. Think about your patient who all of a sudden tells you or goes to his physician for a checkup and tells him that they've developed this very dry, unproductive cough. The first thing we want to do is look at our patient's medications, because maybe this could be a side effect of medications, and one of those medications is a ACE inhibitor, and we'll learn more about what those actually do in regards to the renin-angiotensin-aldosterone system. But for now, I'll just tell you ACEs. One of those side effects from an ACE is a cough. And it's important that we know that, because at that point we can prescribe another drug that works almost the way an ACE would work, but then we can help relieve some of those symptoms of cough for our patients. It's also important to know about the over-the-counter drugs. Our patient has been taking: aspirin, Motrin, things like that, extra vitamins. That's really relevant when it comes to learning about what may be the cause of your patient's respiratory problems. Complementary and alternate therapies are also popular nowadays, so we want to kind of know, are these patients involved in taking, certain herbs or things that they have read about from the internet that may help them with other problems that they may have. Those may help other problems, but they can also create problems too. Think about your patient's health history. Have they had cancer? Has that cancer been treated with things like chemotherapy, which are very toxic? They're anti-neoplastic drugs, and some of them may cure the cancer, but they also provide long-lasting and irreversible side effects. And one of those is pulmonary fibrosis, which is a very deadly respiratory disease. And usually there's no cure. We can palliatively treat that with medications, but it can be a very serious problem for our patients who suffer from respiratory problems. Think about your patients who may admit that they smoke marijuana. It's important to know how often, because a lot of the research out there shows that patients who smoke marijuana, that type of smoke is more lethal to the respiratory system than just cigarette smoke. We know in our communities now there's a lot of problems with overdose of cocaine, heroin, things like that, and a lot of times you may not get that admission out of your patient, but later on, maybe after you build some kind of trust and a good rapport, they may admit that they are users of these particular drugs. Known allergies are important, and we're not just talking about medication allergies. Think about other substances people can be allergic to, any particle, any substance, any food allergy, dust, molds, even pollen. Even people can be allergic to bee stings. And it's important to take it a step further and ask them, what is the allergic response? Do you just break out in a rash? Do you feel like you start coughing a little bit? Does it really truly affect your breathing and you really have trouble breathing? Do you just cough? Do you start sneezing? Do you start having a runny nose? Those are things that you need to know. And then what kind of treatments do you have to alleviate these symptoms? Maybe some people have inhalers. Some people may, if it's a severe reaction where they might have bronchial constriction as well as laryngeal constriction, maybe these patients do carry around with them an EpiPen. So it's important that we document any known allergies and the specific type of allergic response that the patient has. And we know nowadays with foods, they contain a lot of preservatives. So sometimes a person may not actually read the label to know what a certain preservative is in a food, and develop some of these symptoms that they might have. I mean, there can be anywhere from a very mild reaction to a very severe reaction. And obviously we've seen somebody who's in severe respiratory distress where they have severe wheezing, chest tightness, extreme dyspnea. I would say it probably rates about a 4 to 5 on the dyspnea scale. So it's just important that we are aware of that, because obviously our patients will be eating, and we want to make sure that if it is a specific food allergy, that none of that comes near their food tray. Don't forget about travel. Some people, when they go to exotic places or travel to Europe, they may be exposed to certain diseases, fungal diseases. So it's important that we ask them exactly where they went, because maybe we know of some particular outbreak of a certain infection or virus that's prominent in that particular area that they're visiting or vacationing to. Think about family history and some genetic risks. People that have a history of cystic fibrosis, people that are more prone to lung cancers because maybe your parents had cancer. There's also a genetic problem called alpha antitrypsin deficiency, and this puts someone, no matter what age, not due to the fact that they have been smoking cigarettes, but this is a genetic problem where it puts a person at risk for developing emphysema at a very early age. Think about your patients who may have been diagnosed with asthma, infectious diseases such as tuberculosis. Those are things that you want to think about. We know tuberculosis is a very contagious bacterial disease, but we have to look at the CDC, and if you go on that website, you can look up state by state as to what the incidence of that particular disease is. It's low in the state of Ohio, but we still mandate that our students get the man-tooth test so that we can know that they are free of tuberculosis. This was much more prevalent back in the 40s and 50s when we had deep TB clinics, but thanks to good monitoring, the incidence of TB is extremely low compared to what it was about 40 or 50 years ago. But anytime you want to know how many cases of a particular infectious disease or viral disease are, go to the CDC website and it will tell you that, because when these particular very not so common infections occur, the government likes to know what they are, and that particular case is recorded. So that just kind of brings into more of a perspective about how important patient history is, and just specific factors that would be very essential to know about your patient, so that we can kind of make that particular diagnosis with our physicians as to really what is happening with this patient, and really if he has been diagnosed in the past with a certain respiratory problem, we can really look at this health history and maybe do some education with these patients to tell them things to avoid, to slow down the progression of their particular respiratory problems and respiratory disease. I've already talked about smoking in regards to really knowing the years of smoking, the number of packs smoked per day multiplied by the number of years the patient has been smoking. That's really relevant. Talked about all these: drug use, allergies, nutritional status. We talked somewhat about this in class, the importance of really assessing a patient who has a cough, because a cough is not normal. It does signify that there is a sign of lung disease, and when it's quite evident that your patient has a cough, we need to look into things further, because as I said before, a person uses a lot of energy when they cough, and some of our patients really can go into these coughing spells and really have some very serious situations occur because of a prolonged, persistent, harsh cough. And we want to really get to the nitty-gritty of what this cough is all about. Is it happen at a specific time of day? How long has that patient had this cough? is it happen more in the morning or is it in the evening? We know smokers have that morning cough that we hear people who smoke. They cough for quite a while, once they get out of bed in the morning. But many of them, light up that first cigarette in the morning. And once we determine whether or not it's a productive or a non-productive cough, we can definitely assess that sputum. Is it thin? Is it watery? Is it thick? Is it frothy? We talked a little bit about the color of sputum, looking at color, consistency, and odor, and the amount. Is it clear? Is it white? Is it tan? Is it gray? Is it a sign of infection? Because sometimes we see that very purulent and nasty, viscous yellow sputum, or we might even see green sputum. Our patients who suffer from chronic bronchitis, one of the hallmark manifestations of that disease is quite a lot of sputum production, and that is more of a mucoid sputum. When we have excessive pink noted in our patient's sputum, we're talking about pulmonary edema. We classify that as that frothy pink sputum. And please know that when you assess that type of sputum, pulmonary edema is a medical emergency, and you need to get on the phone and definitely inform your physician that that is the kind of sputum your patient is producing, because we need to act quickly or your patient could possibly die. As we learned from that one case study we did last Thursday, the pneumococcal pneumonia can produce what we see as a rust-colored. Think about your patients who may have lung abscesses. I mean, let's face it, no sputum smells good, but lung abscesses may have that very noticeable foul-smelling sputum. Hemoptysis, which is basically blood in the sputum, that could denote that your patient may have, a pulmonary infarction, a bronchial adenoma, or basically just a cancerous tumor that maybe is eroding against the vessel in the pulmonary system. Normally you can your lungs can produce up to 90 milliliters of sputum a day, and it can hold up to about 3 ounces of sputum every day. When we start getting beyond that and excessive amounts of sputum, that's when we'll see our patient become fatigued, and that's when we have to definitely continue to assess, even more. Another thing that we can, possibly see in the sputum are what we call Kirsch spiral cells in a sputum, and this is indicative that your patient does have some kind of problems with their asthma. So it's important when that pathology comes back after you send down a sputum specimen that you look for very specific findings and readings that denote certain diagnoses of your patient. We've already talked about chest pain. I'm not going to get into that again. We went over that in class regarding don't always assume that chest pain means that your patient has some kind of cardiac problem. It could be either pleural, musculoskeletal, or a GI problem. Okay. We've talked about dyspnea, and again, make sure you review your dyspnea classification. It's on a scale of 1 to 5, 1 being there is no breathlessness, and 5 meaning that your patient has dyspnea at rest and restricted to home, and very dependent on others to help them with their activities of daily living. So, and there's a 3 in between. That's significant because just don't tell me your patient's short of breath. Really talk about it in more detail. I talked already in class about PND and orthopnea, and these are very significant. When your patients tell you that they're sleeping on 3 and 4 pillows a night, you need to know why, because that's not normal, and obviously it's due to the fact that your patient can't lay flat. All right. Physical assessment. We went into this the other day. Just a reminder that visual assessment when we're thinking about the respiratory system, looking at color, looking at, the expansion of the chest wall. Are they unevenly developed muscles? Does the patient look like he has pallor or cyanosis regarding his skin and mucous membranes? Does he have no muscle mass? This could be the fact that your patient has a very serious respiratory problem and, just really has poor nutritional intake and, isn't able to really have the energy to eat a healthy diet. When we think of inspection, because that's what obviously we do when we look at that patient and visually assess them, we look at the front, we look at the back, we look at that anterior, posterior, AP or front to back with the lateral, looking at a person, kind of having them turn and looking at them from side to side. Normally we see about a 1 to a 1.5 ratio. And sometimes that can increase when our patients develop certain respiratory chronic diseases, namely one is COPD. And we see that ratio change to more of a 1-to-1, and we call that a barrel chest on our patients. And what's really happening over time, because of the hyperinflation of those alveoli, they cause those ribs to become more horizontal. Normally, with a healthy person, the ribs kind of slant downward normally, but with COPD, it's more of a horizontal type of a look, and that's what pushes out, causing your patients to have what we call a barrel chest. Also, we think about palpation, checking respiratory movement and symmetry, looking for areas of tenderness, and then again, just a little review about fremitus. Fremitus in itself is not real exciting under normal conditions. It's just basically that vibration of the chest wall when the person speaks. You can actually feel the vibration on the chest wall. It's when we determine if this fremitus sounds decreased or feels decreased, or does it feel increased. Think about the physics of how sound travels. It travels much more readily through fluid. And when we're talking about the lungs, a patient who has pneumonia, think about the pathology. The fluid is in the lungs and the alveoli. So fremitus will be increased because you've got that fluid in there which transmits sounds across it much more easily. But then think about a person that when the pleural space is filled with air or fluid, as in a pneumothorax, or with someone who has pleural effusion, the fluid is not in the lungs, so fremitus will be decreased because that transmission of sound is slowed from the larynx to the chest wall because the pathology is very different. Okay, and then of course percussion, meaning that we also auscultate the lungs. It's important that we do that with good assessment habits, meaning pull back the gown, listen from the back, turn off all outside sounds, particularly the TV. If you've got that TV controller with the sound right by your ears, you're not going to be able to hear very good breath sounds. And it's important because you want to determine, not only listening to breath sounds, what you're hearing, you also want to determine if you hear breath sounds, because diminished and absent are very significant as other breath sounds, which we denote as either adventitious or ventitious, okay? And we know ventitious are pretty much the normal sounds. You know, we have normal, which can involve the bronchial tubular breath sounds. They're more high-pitched. Then we can have the bronchiovesicular. Those are heard over the branching bronchi. And then the vesicular, which are more softer, and they're more those soft rustling sounds that you hear in the periphery over the small bronchioles. But then we really are concerned when we pick out sounds that are abnormal, and we call those adventitious. And what they do is they definitely indicate problems and could indicate that your patient has a pathological change or condition. And these can all vary in pitch, intensity, and duration. And that's what our role is, that when we listen for these sounds, maybe at 9 o'clock, they weren't quite as loud or intense. Maybe I only heard crackles at the bases, but then when I gave him 20 milligrams of IV furosemide, and when I went back to listen to him again an hour later, the breath sounds weren't any better. In fact, I also heard him at mid-lobes. That's significant. Many of the terms we give to adventitious breath sounds are crackles, rails, wheezes, ronchi. You can have an inspiratory and an expiratory, pleural rubs, stridor, crackles, and even, as I said before, diminished and absent. Remember, we can also hear wheezes. Sometimes we can hear a wheeze with a stethoscope, and sometimes our patients can go into acute respiratory distress, and we don't even need a stethoscope. We can walk into that patient's room and hear those audible wheezes at the bedside. And this could be due to extreme inflammation. A patient may be having a bronchospasm, edema, or someone that has a lot of secretions, which is causing that bronchial lumen to narrow considerably, causing your patient to develop wheezes. Again, we can be a little more definitive and talk about whether or not they're inspiratory or expiratory. Think about rhonchi, sputum, obstructions by foreign bodies, tumors. Sometimes when it's caused by sputum or mucus, we can encourage the patient to take a nice deep breath and really cough effectively. Sometimes we can hear that the patient is a little clearer because he's able to cough out that obstruction of sputum. Think about pleural friction rub. This has to do with in the pleural space, maybe there's a lot of edema, and as those lungs expand and contract and deflate, we might hear just some kind of rub. Might sound like a little bit like sandpaper. Maybe the patient has some kind of pleurisy or things like that. So just wanted to review that because I really think that's important. And as you begin Nursing 210, I think now you're in an advanced med-surg course, and we have to think like an RN now and really function like an RN. And that's terms that you're going to see on your electronic medical records, and you're also welcome to write nurse's notes depending on what system that you are doing your clinicals in. So I think it's important that you, again, become familiar with these terms. Believe me, this takes years of hearing those sounds, and sometimes we can hear things and we don't know what to call it. Please use your clinical instructors to come in and help you assess your patient's lungs. The important thing is that you do it, and the important thing is that maybe you note a difference from when you listened to your patient earlier as opposed to what you're hearing now. You may not know what to call it, but you've noticed a change, and that's excellent. That's a very, very good start. And maybe your instructor can help you with that, or your nurse that's assigned to your patient. Don't be afraid to ask. That's how we learn. There's a lot of great audio help tapes out there, YouTube, that really help you differentiate between the various lung sounds that you may be hearing. And so, in your spare time when you have it, go on YouTube and, just kind of Google something about breath sounds, and you could spend, maybe 15-20 minutes listening to the various sounds of what does a crackle sound like, as opposed to a rhonchi, as opposed to a wheeze, as opposed to diminished. If you've not had a lot of experience in the past, now's the time to just really become aggressive with that, so you get to hear at least some of those, so you begin to put those sounds together to kind of differentiate what you're hearing. All right, so I hope that's a little bit clearer. Please note that anything that I talk about on this lecture, you're more than welcome to email me probably tomorrow after you listen to this, or we can talk a little bit about it in the first part of the class on Thursday. So if something isn't still clear, feel free to ask me any questions you may have. I want you to feel comfortable when we go into this first test. That's why I'm taking the time to do this lecture. So along with your reading, this just reinforces a lot of what I think is important in the chapter and what I think you're responsible to know. And a little bit of this is review from some of your other med-surg courses that you've had in the program. I'm not going to get into a lot of detail about blood test. We've already talked about red blood cells. We talked about polycythemia. Remember that state of increased red blood cells, poly meaning many, cythemia meaning cells, has to do with the fact that these patients develop hypoxia, and the body recognizes that. So it says, hey, we need some more red blood cells on board because we don't have enough red blood cells to carry the oxygen needed to definitely oxygenate across tissues and cells. So it stimulates with certain factors, erythropoietin, certain vitamin B complexes, iron, all these things needed to make red blood cells. So that's why, because they're in this constant state of hypoxia, this stimulation is continuous, where the person just starts making red blood cells until the time we have just too many. So that's kind of how that process works. I've already talked about sputum. Also, sputum can be a definitive factor. For instance, if your patient has some kind of malignancy and they're coughing up sputum, they can actually detect those cancer cells in the sputum. As I said before, the Kirschmann spirals is a mucus form of more of an allergic asthma, as I talked about earlier, okay? No need to talk again about chest x-rays, but don't forget, every patient that gets admitted to the hospital will have a chest x-ray, can diagnose pneumonia, atelectasis, pneumothorax, even tumor. And some of the time your physician may order a further diagnostic to really make that definitive diagnosis. It can also denote pleural fluid. Sometimes you'll see a reading of pleural effusion, so you want to know what these terms mean. Okay, so my patient has pleural effusion. What does that mean, and where is that pathology at? Obviously, it's in the pleural space, and this is at certain various degrees. So is this pleural effusion bad enough where my patient may need a thoracentesis? Is this what's causing his severe respiratory distress? And if so, what is the cause of the pleural effusion? Because you just don't wake up one morning and develop pleural effusion. There's usually a primary etiology of why that patient has developed that. Again, we use chest x-rays for endotubes, invasive IV, central lines, and PICC lines. We might also do, x-rays of the sinuses if your patients develop things like sinusitis. Some of the more sophisticated, I should say, testing that you may see or ordered on your patient. We've talked about the CT. The most reliable CT would be one with contrast, but not all patients may get that. It depends on a lot of factors, their renal status, previous allergies, things like that. CT is short for computed tomography. The lungs are scanned in successive layers. There's like a cross-sectional view of the chest. It can define pulmonary nodules and small tumors that are adjacent to a lot of the pleural surfaces. Check for allergies, as we always do. Patients should have their allergy band on, so make sure that they do. Old school is if they were allergic to shrimp, because some of the substances in shrimp are found in that actual dye, and so patients are more apt to develop some kind of allergic response to that dye. But a lot of times physicians really want that enhanced CT scan, so they may pre-medicate the patient with Benadryl and steroids and then hang an IV, because the purpose of that IV is to get the dye in quick and then get the dye out. MRI, which is a magnetic resonance imaging, very similar to the CT, except that it uses magnetic fields and radio frequency signals instead of the narrow beam X-ray. And it's a more detailed diagnostic image than a CT. It can characterize pulmonary nodules, help stage bronchiogenic carcinoma, acute PE, chronic thrombolytic hypertension. So that's why we do an MRI. If anybody's ever had an MRI, it can be very claustrophobic for the patient. I've had one myself. It almost sounds like a jackhammer. It's very loud, and sometimes it can be a little bit unnerving for people. So it's really important that we explain that patient in detail, that procedure in detail to the patient, to determine if they're able to tolerate it. Because you're in there for quite a fair amount of time, so you want to be able to endure the sound and the closed offness of that particular diagnostic test. Plus, I think if patients have pacemakers or metal plates in their brain or whatever, those are all contraindicated. So we'll definitely look into the patient's history to determine if this would be the correct diagnostic test for that patient. Fluoroscopy is kind of used frequently. It's to assist with invasive procedures, such as maybe a needle biopsy, performed to identify lesions, study movement of the chest wall, detect diaphragm paralysis, locate masses. They use fluoroscopy in the cath lab to actually inject dye into the coronary arteries to determine if the patients have any blockages or coronary lesions, which would interfere with blood flow through the coronary arteries, thus limiting blood flow to the whole cardiac muscle. Pulmonary angiograms investigate thromboembolic diseases of the lung, pulmonary emboli, or some congenital problems with the vascular tree. What they do is give a radio-opaque agent. It's injected into the vasculatures of the lung for radiographic study of the pulmonary vessels, and they might go through the femoral vein. Lung scans, VQ scans, gallium scans, and PET scans are also other types of more precise and a little bit unusual types of diagnostic testing. They assess normal lung functioning, pulmonary vascular supply, and gas exchange. Your VQ scan, I talked a little bit about that in regards to diagnosing a pulmonary emboli. What they do is they give a radio active agent to the patient, IV, and these isotopes pass through the right side. They're distributed into the lungs in proportion to the regional blood flow, and they check blood perfusion through the lungs. The imaging time takes about 20 to 40 minutes. And the patient, when he goes in for this exam, he'll lie under a camera with a mask fitted over their nose or mouth, because we're not only looking at perfusion now, we're going to look at ventilation. So now this is the ventilation component of the test. And so we ask the patient with that mask on to take a very deep breath of a mixture of O2 and radioactive gas, which also diffuses through the lung. And this scan is performed to detect ventilation abnormalities, can help diagnose bronchitis, asthma, inflammatory fibrosis, pneumonia, emphysema, and lung cancer. So ventilation without perfusion is seen with a patient who is diagnosed with a pulmonary emboli. So wanted to kind of go over that with you so that if you see that type of diagnostic testing, the results will make a little more sense as to how they came up with that reading. Gallium scan is another. Gallium is a radioisotope. It's a lung scan used to detect inflammatory conditions, abscesses, adhesions, presence, and location and size of tumors. And again, gallium is injected IV, and scans are taken at particular intervals. A PET scan. PET is an acronym for positron emission tomography, and this is a diagnostic testing which has the capability to evaluate lung nodules for malignancies, distinguish between disease and normal tissue. This really is a very sensitive test. It can really denote different color changes, which would denote maybe metastasis if a person has a primary tumor, has that gone to another part of their body. They're kind of cool to look at because they come out in colors, and honestly, it's very sensitive. It'll pick up any abnormal cells or tumors, and that's the kind of information we want to know to determine what's the treatment, because some patients who have already had metastasis of their cancer, maybe they will just want palliative treatment and not undergo a really big and long surgery, which would not justify that, they would be cured. Okay. We've talked about pulse ox. It's a non-invasive method of continuously monitoring the O2 saturation of hemoglobin. The normal is about 95 to 100%. Anything under 92% we get concerned. Anything below 85% indicates that tissues are not receiving enough O2, and what we need to do now is find out why. What's the cause? Things that may affect the results are a patient who might have high carbon monoxide levels, somebody who has severe anemia, methylene blue, and any kind of medication that causes vasoconstriction. Okay, remember, it's those results of a pulse ox are picked up on infrared light. So if, for instance, your female patients have acrylic nails or certain types of nail polish, if you're doing the test maybe on the right or left index finger, that would maybe throw off your results, because look at your patient. If you get a reading of 82% and you look at your patient, they're fine, their color's good, they're breathing well, then there's probably some problem with the machine or some other kind of barrier or problem that's giving you such a low reading, because it sure doesn't correlate with what you're seeing in your patient. Your patient looks really good. I've already talked about pulmonary functions. It assesses that respiratory function and determines the extent of the dysfunction. Looks at lung volumes, ventilatory function, mechanics of breathing, diffusion, and gas exchange. We might do this to diagnose. We might look at response to therapy. We want to see if there's any serious aftermath effects if a person has been exposed to harmful substances, a coal miner, asbestos, or even some noxious or toxic fumes. So that's what we would maybe possibly see those ordered for our patients. Maybe a patient is going to have a very long and very complex surgery. The patient may be ordered to have pre-op testing to make sure that their lungs can sustain a surgery that difficult or a surgery that long. It's usually performed by a technician, and also it's important to know that with pulmonary functions, they take in consideration a patient's gender, race, height, weight, and smoking to determine what's normal for that patient. You might have a patient too that not quite sure why they are having continuous dyspnea, especially if it's pretty severe, at that classification of either 4 or 5. We just see them short of breath, but we can't figure out what exactly is going on. Remember, no smoking 6 to 8 hours before, withhold certain drugs such as bronchial dilators, and that technician and physician will definitely interpret those findings. Exercise testing, think about it. We assess the ability of a patient's ableness to work and perform their activities of daily living. Can they feed themselves? Can they take a bath? Can they dress themselves? What household chores can they do? Because remember, it's added activity, needs added oxygen demand. So also there's a need for increased metabolism. So we want to make sure that the patients are able to do those at home. They may use a treadmill, a bike, a walking test for 12 minutes. Closely monitor, relieve anxiety. Just let them know that they're always being watched, that if there's any problems or serious complications, we can stop the testing and treat the problem accordingly. Think about skin testing, TB, mono, mumps, fungal diseases, exposure to allergens and infectious diseases. It's also important to look at mono. I mean, we take that a little bit lightly, but as we further advance through Nursing 210 and study some of these other systems, some of these severe hematological problems, they've looked at a patient's health history, and for instance, patients who develop lymphomas, they look and see that patients that have had a type of mono in their past, they're a little bit more prone to develop some of these problems. Now, I'm not saying all patients that have mono are going to get cancer, but I'm just saying there is some correlation that mono can be a precursor for patients to acquire some of these diseases. Okay, so that's all about other testing and follow-up care. And then the big two that I want to kind of talk to about in detail is the bronchoscopy as well as the thoracentesis. Okay, there are other endoscopic exams. One that may sound a little familiar is the laryngoscopy, which is looking at the larynx. Okay, we're looking at the vocal cords. Sometimes we're looking for foreign bodies in the larynx. Maybe we suspect that our patient has a malignancy, cancer of the larynx, so we might want to see the physician do a biopsy or a culture and obtain some type of tissue samples. Maybe the patient has developed those signs and symptoms of like voice hoarseness, and that is why they might do a laryngoscopy. Okay, there's also what we call a medianoscopy. Think of your mediastinum. We can't advance a tube to that area because of where it sits, the mediastinum. So this has to be done by an insertion of a tube through the chest wall above the sternum into the area of the upper chest between the lung. The patient has to be anesthetized for this. Patient has to go to the OR. It's considered a surgical procedure, and we're checking for tumors and obtaining samples of tissue. Think about it. Patient gets anesthesia. We want to make sure they don't develop respiratory complications, okay? And also because it is invasive, where it involves insertion of a tube through a needle initially, and then it's cannulated, we watch for complications of bleeding, okay? The one that's a little bit more familiar is a bronchoscopy, and think about where these testings are being done at, what particular part of the anatomy are we looking at, or I should say the physician. We're looking at the bronchioles, okay, and that makes sense. And what the physician is able to do is view those airway structures, take samples, take biopsies. He may do it to remove a foreign body. He may do it to, or she, do it to remove secretions. Another reason is to treat post-op atelectasis. You know, think about it, a person is in surgery a long time, those lungs are not really getting inflated real deep. You look on a chest x-ray and see that they've got a little bit of some atelectasis going on. They can also do a bronch to destroy and excise lesions, and also for the insertion of stents. We don't necessarily have to send a patient to surgery to have this done. But think about it. We're putting a tube down the patient's bronchioles. We have to bypass that gag reflex, so that has to be kind of diminished, if not eliminated, so the patient isn't constantly coughing. It would be very difficult to do this type of procedure. So the patient does have to have numbing medications, and we'll talk about that in a minute. Since it is an invasive procedure, you do need a permit, and you want to verify that that consent was obtained. The physician who's doing it should be explaining the procedure to the patient to help eliminate or decrease their fear. They may give some atropine or opioid pre-op to diminish that cough reflex. Then there's a vinyl verification, and that's made possible by order of the Joint Commission. Let's look at some lab work prior to doing this. A CBC, platelet count, PT, electrolytes, and chest x-ray. And that all makes sense. We're kind of doing a bleeding coagulation panel on these patients, because if we're snipping some of the tissue, we don't want our patients to bleed in their lungs or in their bronchioles. They're NPO 4 to 8 hours. And that's to obviously avoid vomiting during the procedure and during the diagnostic study. They may pre-medicate. If the patient has dentures, we want those removed. Do a good thorough assessment prior to the patient going down. And obviously when they return to the floor, the big thing is make sure they have a gag reflex. And that's also assessed before we even attempt to give them even a sip of water. So make sure families are aware that when their husbands or wives come back, that they're not automatically giving that to their loved one, because they know how thirsty they are, and they want to make them feel better because they probably will have a dry mouth, particularly if they had some atropine. They use lidocaine spray to kind of numb the throat and to kind of desensitize that gag reflex. They don't use benzocaine spray, oral pharynx, much anymore, because it can induce a condition called methemoglobinemia. It doesn't always do this, but we have to use it very cautiously in case it does. And what happens is there's a conversion of normal hemoglobin to more of a methemoglobin, and this is very serious because as that condition advances, it alters iron state that does not carry O2, resulting in the patient developing tissue hypoxia. So that's why they use the lidocaine instead. Normally blood levels of methemoglobin is less than 1%, but when that increases due to the fact that they use that benzocaine spray, that level increases, which obviously causes a decrease in tissue perfusion, or it can be severely reduced. The first sign that a patient may be experiencing this condition is cyanosis. Then they get anxiety. We see that in about 20 to 50% of the cases. Death can also occur. And even the blood changes in color. It becomes more of a chocolate brown. And what do we do to treat this? If we suspect that the patient has developed this, we provide supplemental O2 and give the patient methylene blue, 1 to 2 milligrams per kilogram. We again assess our patient's respiratory status, especially how well they're ventilating. We watch blood pressure, pulse, respiratory rate, and O2 saturation. So that is just something about the gag reflex and about a complication of benzocaine spray. All right. So if you're wondering why they only use the lidocaine, that's why. This last one that I'm going to talk about is the thoracentesis. Remember where we're at when this procedure is done. We're aspirating contents out of the pleural space, usually aspiration of pleural fluid or even air from the pleural space. We do it for that reason, to remove fluids. We may do an analysis of the tissue. We may do a pleural biopsy, or we can also do a thoracentesis to instill drugs, instill medications. We can also diagnose or treat cancer, emphysema, pleurisy. If a patient has TB, this is what we would do to install drugs in that pleural space. Okay. The reason we do this is, if it's to remove fluid, the purpose is to have that pleural fluid drain to relieve blood vessel or lung compression, so the person can breathe a lot better. And you don't want a lot of pressure on those vessels, because it can cause bleeding to occur. Again, we want to explain in its entirety what exactly is going to happen to the patient. They will do a numbing of the area before they actually cannulate it to drain out the fluid. All the patient should feel then, if the numbing medication has taken effect, is more of a pressure when the needle is inserted. And it's absolutely essential that the patient keep perfectly still and does not move. The position is essential to preventing any serious complications. And that's where we as the nurse come in to be. I'll show you this picture here on the slides, and you probably saw it when you looked at this. See how the patient is kind of leaning back. This kind of opens up the pleural space, and the nurse is just in the front. Make sure that that bedside table doesn't slide, and you can see where the patient is being kind of held on by the nurse, kind of holding her arms. And it isn't too invasive, but just enough to prevent and remind the patient definitely not to move. Sometimes we can do this by CT guidance. We want to make sure the patient's comfortable, verify allergy, especially to any numbing medications. They want to sign a permit. Our goal not only is to support the patient emotionally, but also to watch for some real serious side effects of shock, pain, nausea and vomiting, pallor, diaphoresis. They might use an 18 to 25 gauge needle. The book talks about not removing more than 1,000 milliliters, but I've seen physicians remove a lot more than that. Sometimes they're worried about mediastinal shifts, but it just depends on what the purpose is and the physician and what his philosophy is concerning how much to remove. When it's all said and done, first of all, before you begin the procedure, make sure you have all the necessary equipment in the room for the physician, because there's nothing worse than the physician kind of getting upset with you because not everything was in the room. The patient has to wait longer. They're getting a little bit perturbed. And it's a little bit embarrassing if the physician starts getting angry and yelling at the nurse. Not that we can't, endure it, but let's think about the patient. So get everything in there, that you may need. Ask an experienced nurse on the floor, especially one who's worked with that particular doctor, exactly what you need in that room, okay? And that's really about all. Usually when that is removed, you just apply pressure, and usually there's just a very small sterile dressing. Our big concerns post-op are pneumothoraxes, and if one does occur, mediastinal shift, pulmonary edema, increased pain. There should not be a lot of pain post-procedure, and if that pain keeps getting worse and worse and worse, that's really something to look into, because it should not get like that. You definitely need to document the procedure and then send specimens to lab correctly. And that's really important. Don't leave them sitting on a counter and assume that the secretary or another nurse is going to take it down. It's your responsibility to make sure that those specimens get down to the lab immediately. Things like urine that's sitting out more than 15 minutes or a half hour, the specimen is no longer good, and so you don't really want to send those down to the lab, because you want them to be just recent specimens, so that we get accurate lab values on those particular specimens. And the same goes for urine, same goes for sputum, things like that. Usually if we're concerned about a pneumothorax, it's probably going to happen in the first 24 hours. Pain on an affected side could also cause rapid heart rate. Air hunger increases, tracheal shift. Check puncture site. Kind of palpate around and see if there's any sub-Q emphysema, and that's that. Feels like snap, crackle, pop, popcorn, or Rice Krispies underneath, and that is what we call sub-Q emphysema. All right. Think about attention pneumothorax. We talked about that the other day, and so those are the things you're going to watch out for. And the last thing is your lung biopsy, and that's obviously to perform kind of examination of the lung tissue itself. They can do a percutaneous lung biopsy, which is very similar to a thoracentesis, or they can actually do an open lung biopsy in the OR to either the upper or lower lobes. May need a chest tube to reinflate the lung. Vital signs, breath sounds every 4 hours, looking for hemoptysis, frank bleeding. If you hit one of those big vessels in the lung, you could end up with a lot of problems and a lot of bleeding. So a lot of times this particular exam is done by CT guidance. And obviously the big complications we're concerned about is respiratory distress because of possible infection, possible bleeding. Did he give my patient, or she give my patient a pneumothorax? That's why listening to vital signs, they say every 4, but I sure would do them well, obviously it's every 15 for the first hour, but even that I would do it even more frequently. The first hour, I would do it again in an hour, and then maybe to 2 hours, and then to 4, but I wouldn't go right to 4 because anything could change in that window of 4 hours very quickly. Listen for any reduced or absent breath sounds, and we know what the signs and symptoms of losing blood are. increased heart rate, decreased blood pressure. And so you want to watch for things like hemoptysis. Is the patient bleeding? Is there a lot of bleeding that he's coughing up? Not a good thing, especially if it's bright, frank red bleeding. Okay, you need to notify your physician immediately. So these are other diagnostics. Pleural biopsy detects TB or fungus infection, and then a lymph node biopsy indicated if the scalene lymph nodes are palpable. So that's that, and this is just a little critical thinking exercises. It's on a 55-year-old patient. You can kind of look at that on your own. All right, I'm getting ready to put up oxygen therapy and tracheostomy, so we'll just go right into that. So again, if there's any questions on any of this assessment information, feel free to send me a text or to ask me the questions in class this week. All right, stay tuned for oxygen therapy. Now I'm going to talk to you about oxygen therapy and about tracheostomies and some of the responsibilities that we have when our patients do have tracheostomies. So first of all, let's look at oxygen therapy. This is quite familiar to most of us. Many times we've been taking care of patients who do have oxygen, but I do want you to take this type of treatment for our patients very, very seriously, okay? Because the goal of oxygen therapy, as it says here on this PowerPoint slide, is to use the lowest fraction of inspired O2. An FiO2 that results in an acceptable blood O2 without causing harmful effects. Remember, it improves the PaO2. It does not cure the problem or stop the disease process. And we want to provide this oxygen to our patients without causing harmful side effects. And I think we have to understand that it can, because it's a supplemental order that we provide our patients, hoping to increase their PaO2. But sometimes that's not the case, because everybody reacts differently to certain therapies that we use in the treatment of their diseases. Look at these two terms, hypoxemia and hypoxia. And, it's important to understand the definitions of these terms, but think about what that really means. When we talk about a patient who is suffering from hypoxemia, they have low levels of oxygen in the blood, and this isn't good, because the hypoxia will definitely have decreased tissue oxygenation, cell oxygenation, and we want to make sure that organs are properly being oxygenated, particularly things like the brain, the heart, the kidneys, things like that. So this is a very serious situation, and we then have to look at the pathology of our patients as to why their PaO2s are low and why we need to implement oxygen therapy, and really what's the best therapy for this patient to prevent those harmful side effects from happening. And I think people think that oxygen is perfectly safe, and for most patients it really does good for them, but it can. So our goal is to provide oxygen therapy that really will increase that PaO2 without causing our patient some harmful side effect, okay? Some degree of hypoxia requires usually some kind of O2 flow of probably nasal cannula at 2 to 4 liters, or maybe at least a 40% venti or ventura mask. And we're going to talk about those specific types of oxygen therapy, looking at low flow versus high flow. Think about your patient with a chronic disease such as COPD, hypercarbia, where we have to be very careful to keep that CO2 level high, that PaO2 level low. We may increase it somewhat, but not to the point where, it affects and knocks out their hypoxic drive, which we're going to talk about in a few minutes. Think about our patients with respiratory problems. When patients can't breathe, anxiety causes them to become hypoxic, suffering from low levels of O2 in the blood. And with that, we begin to see those first initial signs and symptoms of hypoxemia, where they might have acute confusion, restlessness, things like that would indicate that something is wrong. How do we measure the PaO2 and the CO2 levels of our patients, and even wanting to know that third value of pH? Well, obviously the best measure for determining the need for O2 therapy is arterial blood gases. And we as nurses make those assessments that, hey, my patient does not look good respiratory-wise, respiratory rates increase, color looks bad, lungs sound bad. We've made a definitive diagnosis on the patient, and we really feel that this patient would benefit from some type of O2 therapy. So we suggest and recommend to our physicians to have ABGs if he's not already ordered them. And that way we can best determine exactly where our PaO2 levels are, PCO2 levels, and where our patient's pH is. And then we as nurses have that ability to interpret those blood gas results. And along with the collaboration with respiratory therapy and the physician, we can best determine what oxygen would help our patients the best. We're always using pulse ox for our respiratory assessments when we make that morning assessment on our patient, even every 4 hours, or how often we do vital signs. It's kind of like one of those other measurements that really help us determine our patients' oxygen levels, and really they're very comparable to what your patient's PaO2 levels would be. Think about when our patients have problems with their respiratory system. Watch for secretions. They can serve as an obstruction. The important thing is we need to maintain patent airways at all times. Taking care of the equipment, make sure it's functioning correctly. Please, I can't recommend enough that we use the respiratory therapies in our hospitals to help us with the care of our patients, because they are the experts in this field as far as recommendations on what to use for these patients, and as well as for setups, for change of oxygen therapies. They're there at a time when maybe your patients are going into acute distress. They're there to supplement these patients with oxygen, make sure that the equipment is functioning correctly, provide respiratory treatments, draw arterial blood gases, maybe be in control and manage ventilators, mechanical ventilators, which you'll get experience with in nursing 213 or critical care, or they may be managing a patient's CPAP or BiPAP machine. So these are all things that we can kind of work with a respiratory therapy. If your patient is on, BiPAP or CPAP at night due to sleep apnea, and maybe you're working the night shift and the alarms are going off, you may want to call respiratory down there to kind of say, hey, what's going on? Are all the alarms set correctly? Is there some problem with the patient that these pressure alarms are going off? They can hopefully answer those questions for you. You want to make sure that what is ordered is being delivered, and we're going to talk about why a patient may have low flow oxygen provided to them rather than a high flow. And we want to make sure is it effective, because usually when we start a patient on oxygen or we change their oxygen therapy, we're doing that continuous assessment. Are they doing okay? Before we put on oxygen for the patient, his respirations were 18. We put on 3 liters of oxygen, and now he's breathing 7 times a minute. There's a serious problem going on here, and is it due to the fact that we've knocked out somebody's hypoxic drive and they're not breathing as much anymore? This could be very, very serious. We want to make sure that that oxygen that we're providing our patient does not interfere with their own attempt to breathe. You know, we want to look at for some of these particular harmful side effects, which we're going to talk about in a few minutes. And we want to make sure that the patient is wearing the device correctly. You know, is it causing them friction on the face? Is it causing them skin breakdown? These are kind of the responsibilities of the nurse. And respiratory is very, very good when they come in and make rounds and check their patients. I mean, they're not with the patient as frequently as we are, but they really do take some of that responsibility also. Think about your patients that need to be transported with oxygen. Is it being done correctly? If they're using an oxygen tank, does it have enough oxygen so if the patient's down in X-ray for an hour, will that oxygen be sustained, or is the cylinder going to run out of oxygen? What about a person who has oxygen at home? What do I need to teach my patients about that? And are they candidates where this might be paid for? You know, you might want to look at the patient's method of getting around, and does that O2 facilitate mobility? Does it provide patient safety? You know, if your patients are on a high liter flow with a nasal cannula, do you recommend that they have humidity so they don't have skin breakdown or mucosal breakdown, or the drying up of mucosa and mucous membranes? Also, teaching our patient, if they go home on some of these oxygen therapies, how to take care of the equipment, how to clean it, making sure that the equipment is sitting well on the face, that it's not pulling on the patient, that if they do go home on oxygen, there's no smoking, no lit candles. It really is a situation where we want to provide that patient ongoing teaching. And these are just some of the highlights when we're talking about oxygen therapy that we need to keep in mind to keep our patients safe and to hopefully provide an increase in their PO2, which hopefully provides us better patient outcomes. This is just that balance between oxygen intake, oxygen delivery, and again, oxygen delivery through blood vessels and red blood cells. There are certain hazards and complications of oxygen therapy, and some of these we might be more familiar with than others, but I'll just kind of go over these quickly. When we talk about combustion, you know, I've had some instances where patients have been on oxygen and you know, we tell them not to smoke, and they go in their little bathroom and they smoke cigarettes. We got to be really careful, because usually O2 itself does not burn, but it supports and enhances combustion, and we don't want something to spontaneously combust and cause our patients to develop or to you know, get burns from that. And usually we don't see this happen with at least a 50% oxygen delivery, but it is important that we continue to teach our patients the hazards of smoking around oxygen, as well as open candles, especially if they go home, that they have safe electrical equipment, it's grounded properly, there's no arcing or sparks, patient doesn't have their oxygen around frayed cords, or there's no alcohol or oil solutions which would promote that type of combustion. So it's about patient teaching, patient safety. This is the one I just talked about earlier, oxygen-induced hypoventilation. We assess with patients whose main respiratory drive is hypoxia. And think about our patients that have COPD. They have high levels of CO2, which we call hypercarbia. And usually their CO2s are high and their PaO2s are low. That loss of sensitivity to high levels of PCO2 is called CO2 narcosis, and that decreased O2 level is their hypoxic drive to breathe. So that's why we put our patients with COPD who need a little boost with their PaO2. Maybe it's in the 50s or 60s when they come in due to some kind of disease process. They develop pneumonia. We want to get that PaO2 up a little bit more, but we have to be careful because we can't put them on 5-6 liters of O2 specs because we don't want to increase that oxygen level too high because it knocks out their hypoxic drive to breathe. So usually O2 for those types of patients with COPD are prescribed at 1, 2, and 3 liters. More precise O2 levels such as a Venturi mask is preferred. But patients with COPD, you're going to find, if you haven't already noticed, they do not tolerate face masks very well. They just have that feeling of claustrophobia. They can't breathe well. They feel like they're being smothered. Usually, if your patients are going to have a respiratory change, maybe due to decreased respiratory rate, due to maybe too high of a flow on that oxygen per specs, we're going to see that change probably within the first 30 minutes of when we apply or implement that particular O2 therapy. Our role with all this is good monitoring, good assessment, looking for patients developing respiratory depression. And we look for things like level of consciousness. What's their respiratory pattern? Before they were put on this particular oxygen therapy, their chest was rising symmetrically. It was a nice, deep, inspiratory effort, but all of a sudden, 20 minutes into this, after I put those cannula on at 3 liters, I see that his chest isn't rising more, and he's only breathing now, 10 or 12, or before he was breathing 18 to 20. And remember, hypoxemia is really a great threat to life. So you want to definitely keep that in mind. Think about what is going on systemically with your patients when they develop a hypoxemic state, okay? This other one, oxygen toxicity. I'm not even sure if you're aware that you can become toxic with oxygen, but yes, you can. This usually occurs if we're giving high concentrations of oxygen. When we have to continuously increase that oxygen percentage to 50% or higher, obviously we have definitely a diffusion problem where there's improper gas exchange, okay, due to some kind of pathology in the lungs. And what oxygen toxicity entails is if we give these high levels for more than 24 hours, it can actually damage the lungs, okay? And sometimes it can be as long as 48 hours. So that's why it's really important as nurses that when we hear a report, particularly if you are taking care of a patient in like a critical care area, this is where you see these high percentages of oxygen given to your patient because they're very, very sick and have some very serious respiratory problems. You want to get report from the nurse and say, hey, he's on 55% mask or whatever the case may be. How long has he been on that? Because if he's only been on it a few hours, that's much less significant than if he's been on it for a day already. Then maybe you really want to watch for signs and symptoms of those toxicity because he's been on it for that long of a time period. They start seeing those same symptoms as somebody that has ARDS or adult respiratory distress syndrome, and what we initially see is they have a non-productive cough. That's where it kind of starts. So if you see your patient starting to cough a little bit, and it doesn't mean that that's the reason, but really be more attentive because if it's not really picked up, then you may see advancing some symptoms like substernal chest pain, GI upset and dyspnea. Prolonged exposure to high O2 levels can actually damage lung tissues where the patient can develop serious complications such as atelectasis, pulmonary edema, hemorrhage. Hyaline membrane formation can result. So, of course, patients will have decreased vital capacity of their lungs, decreased compliance, increasing dyspnea. Maybe they'll start developing crackles. Sometimes the alternative for such a high percentage of oxygen is maybe we might switch the patient to a CPAP, which is a continuous positive airway pressure with an O2 mask, or they might put them on a BiPAP, which is the positive airway pressure involving two pressures as well as inspiratory and expiratory, or if they're on a mechanical ventilator, we may put them on PEEP, which stands for positive end expiratory pressure when the patients are on a mechanical ventilator. But it's just something to be aware of, because I don't think we think of that, because we think, oh my gosh, the patient needs that high percentage of oxygen, but really he may for a short period, but we can't keep it on him indefinitely because it can actually cause lung damage and all those unfortunate complications that I just talked about. Absorption atelectasis. Think about nitrogen. Makes up about 79% of room air, and the other 21% is oxygen, okay? So if, and that nitrogen is a good thing because that's what helps maintain patent airways and prevents your alveoli from collapsing. So if we again give high levels of O2, it kind of dilutes the nitrogen. The O2 diffuses from the alveoli into circulation, and guess what? Your alveoli will collapse, and guess what? You have poor diffusion. It's going to affect your respiratory rate and definitely have very poor ABG results. So we want to monitor, for crackles. We want to listen for breath sounds, especially every 1 to 2 hours. We can detect this problem. Obviously, we're not going to hear good breath sounds and good exchange of air. So we would detect this by auscultating the patient's lungs, okay? So when this is started, especially high concentrations, you want to make sure that the patient doesn't develop an absorption atelectasis, which makes sense. And you're going to see that begin in the lower portions of the lungs, okay? The next one is probably a little more familiar. The drying of mucous membranes, O2 flow rate higher than 4 liters, humidity is added. And we used to have these in the acute care setting, usually in the clean utility room. I'm not sure if they're keeping this equipment on the floors because we want to make sure we're getting the patients charged with these supplies. But if you don't have it on the floor, just call Respiratory and they can hook up a humidity bottle. If you do it and the equipment is on the floor, make sure you're doing it correctly. Make sure that it is delivering the flow rate that's been ordered because that little bottle should be bubbling. Know the policy of how often these humidity bottles should be changed, because obviously the higher the flow rate, the more of that water will be evaporated. But maybe the policy is that they're only supposed to be up for like 24 hours. I like to mark things, so I would mark, in a magic marker on the bottle when that was actually hung, so you kind of have an idea how long that humidity has been up. Because the problem with that is it's wet, it's a great media for bacteria, and you don't want that getting into your oxygen, the humidity bottle, because you don't want your patients inhaling that, because the culprit most associated with this is Pseudomonas. And so we don't want our patients having that. Humidifiers can be good for our patients, or nebulizers, but they can also be a source of infection. So just be aware of the policy in your hospital, and you can ask Respiratory, are they responsible to change it? They're usually very, very good about this. So maybe the policy in some areas are every 24 hours, okay? All right. So that's some of the hazards and complications of O2 therapy, okay? We're going to talk a little bit about now high flow and low flow oxygen. Oh, let me just show you this picture on the slide of the oxygen source, what goes to the patient, and this is sterile. And remember, this is filled with sterile water. Okay, just so you know what kind of a solution this is. It's not saline, but it is sterile water. Okay, so just so you're clear on that. All right. All right. Now we're going to low flow oxygen delivery systems. I've got the next slide up here. The first question, just to kind of throw out at you, is what do we mean by low flow versus high flow? And that is a great question. The main difference is low flow, we can't always be sure that when we provide this type of oxygen that's precisely what we're delivering to the patient, because it really depends on the patient and his respiratory effort, how deep his respirations are. So for instance, if we put a patient on a nasal cannula at 4 liters, we know that when our patients are on 4 liters, they're getting certain percentages of oxygen, and we don't know if they're precisely getting that because it really depends on your patient's respiratory status and what kind of a respiratory effort he's providing. So it is pretty close to what is being ordered, but it isn't always that precise amount of oxygen that is being delivered. Now, when we talk about our patients that are getting high flow oxygen delivery systems, those are more precise. So when we say that our patients are getting 50% venti mask, that's what they're getting, and it really isn't dependent on your patient's respiratory status. That's pretty much what they're getting. Okay, so just want to tell you that. So as I said before, if they were on 4 liters, it's estimated they're getting about 36% oxygen. So we're not always sure that they're getting that 36% oxygen. So that's pretty much the difference between low flow and high flow. So let's talk a little bit about nasal cannula. And we're really familiar with, a nasal cannula. We see this picture here, and we call it nasal specs, nasal cannula. We can only provide our patients or give our patients the highest amount of oxygen is 44%, and that's at 6 liters. So that's as high as we can provide our patients with this type of therapy. 1 liter would be, 24%, 2 liters is 28, 3 liters is 32. It goes up by 4 percentages of oxygen, 36, 40, and 44. So, but remember again, we provide very low flow to our patients with COPD. This is a very frequent means of oxygen therapy for our patients who have COPD, patients who need long-term therapy, patients who retain CO2, usually never higher than 2 or 3 liters, because again, we don't want to lose that hypoxic drive. When patients who do not have COPD are on this type of therapy, maybe at 4, 5, 6 liter flow rate, they're very prone to drying out the mucous membranes and to mucosal irritation. So that's why a lot of times we put the humidity on those patients. Not effective, as I said, over 6 liters, does not increase oxygenation because of the anatomic dead space, and we know what dead space is. Those are places in the lung where air flows, but the structures are too thick for gas exchange, okay? So that's a nasal cannula. Again, make sure it's put on correctly. I don't want to preach about our responsibilities, but it is very concerning to me when I walk into a patient's room. They're supposed to be on 2, 3, 4 liters of oxygen. The prongs, one's in out of their nares, the other one's not in their nares. The oxygen's sitting on their head. The oxygen's been taken off. It's laying in the bed. Patient comes back from an x-ray. Nobody turns on the flow meter. These are all kinds of things I've seen with oxygen because they think, oh, it's no big deal. It's only a nasal cannula. Yes, it's a big deal. It's oxygen therapy. This particular amount of flow was ordered for the patient, so we need to make sure that's what our patients are getting. What if the patient says to you, I don't want that on anymore, I'm breathing fine? Then that needs to be reported to the physician, and then maybe the order needs to be discontinued, or the physician can write nasal cannula PRN. As long as you feel that it's safe for the patient to go without that therapy, their pulse ox is good, their respiratory status is good, then that's fine. But otherwise, that nasal cannula should be on your patient, and it should be on correctly. That your patient isn't having skin breakdown, that it's not pulled too tight, if they have connective tubing on it, that the patient is safe when he gets up to walk to the bathroom, that he's not going to trip over it. And we don't want too much extension on that because that also creates dead space, and we want to make sure as much of that 3 liters or whatever's ordered is given to that patient, because with dead space, some of that is going to get lost in that tubing, and your patient will not be getting what has been ordered. This is a common type of therapy that we give a patient maybe when they come out of surgery. They've just had a general anesthetic. We put a little O2 on them, try to get, their oxygen levels up, kind of, stimulate them to get them breathing on their own. Very, very widely used if they happen to get soiled with sputum or whatever. If they can't be cleaned, throw them out and get another cannula. We don't want any bacteria harboring on those. These are what patients usually go home on. It's really the oxygen therapy of choice. But we want to make sure our patients understand, how to use it. Okay? So that's, excuse me, nasal cannula. I don't think I need to say any more about that. Okay? The only thing, I guess I will say one more thing, sorry. Make sure your patient has patent nares. One thing that can obstruct the nares, or maybe a patient has developed nasal polyps because they're not going to get that airflow going in through the nares to properly oxygenate them. So that's one thing you want to make sure that the prongs are in correctly. I've come into the patient's rooms where they've been kind of inverted the wrong way, and they're kind of digging into the patient's nostrils. I know it seems so easy, but these are the things I've seen over the years, and I'm just kind of passing that on to you if you've not had the same experience. I've seen a lot. All right, the next one is a simple face mask. All right, you can see from the picture, you can see why patients maybe with COPD can find these a little bit constricting, claustrophobic. They're used to give patients anywhere from 40% to 60% oxygen. You would definitely put that liter flow up to at least 5 liters for 40%, and between 55 and 60% you would probably increase it to 8 liters. You need a simple face mask at least at 5 liters per minute to prevent the rebreathing of exhaled air. All right, this is used for short term or maybe for an emergency. And as I said, you want to always make sure that it is at least 5 liters per minute. Okay, so that's important to know. All right. So that's a simple face mask, which again is low flow oxygen. All right. Sorry about this, but going back to nasal cannula. Again, one of the disadvantages with a nasal cannula is the fact that O2 delivered varies and depends on the patient's breathing pattern. O2 can be diluted with room air, and remember, 21% of the room air is oxygen, which lowers the amount of O2 that the patient actually inspires. So that's what I said before, and I just wanted to make that clear, that it's a frequent method, but sometimes it probably isn't the best choice for our patients, okay? So just wanted to kind of go over that with you. Let's see. Again, just make sure your simple face mask fit properly, okay? We're still continuing with low flow oxygen deliveries, and the next one is a partial rebreather. And as you can see, that equipment is a little bit more complex than a simple face mask. A partial rebreather can provide up to 60 to 75% of oxygen to our patients, and that can be anywhere from 6 to 11 liters per minute. Look at that picture, and you'll note that there is a reservoir bag but no flaps. That bag needs to be slightly inflated at the end of inspiration to make sure that the patient is getting the prescribed amount of oxygen, okay? They breathe about 1/3 of the exhaled tidal volume. And as I said before, that needs to remain slightly inflated at the end of inspiration. Otherwise, you will not get that desired amount of O2. So again, partial rebreather provides anywhere from 60% to 75% of oxygen to the patient. All right. Now the non-rebreather is the highest level of O2 for low flow oxygen delivery. As you can see, it has a reservoir, but this one has flaps. And those flaps are there to prevent room air from entering through the exhalation ports. Because if you had room air come back into the system, it would dilute that oxygen, and this is one that really provides a very high flow of oxygen, 80 to 95% of FiO2. That reservoir bag needs to be about 2/3 full, and again, to get those high levels of like 90 to 95% really depends on how the patient is breathing. This is used when you have a patient who has a very unstable respiratory condition. At this point, the next alternative would be possibly intubating your patient, okay? When your patients are on non-rebreathers, the patient is very acutely ill and has a very, very severe respiratory problem, okay? So remember, there is that one-way valve between the mask and the reservoir, and there's 2 flaps over those exhalation ports. The bag's inflated during inhalation, and usually we turn up the liter flow to about 10 to 15 liters, depending on how much oxygen we want to deliver to the patient. So those are the 4 methods of low-flow oxygen delivery. And if, for instance, your physician orders that, you definitely want respiratory up there to definitely make sure that we are applying and putting this equipment on correctly, so we're delivering what the physician has ordered. Because I said, usually with partial and non-rebreather mask, these are very serious situations that's occurring with your patients. Don't ever assume that you're doing it correctly. Have respiratory come up and do it for you, okay? I had a student one time that thought she knew how to set up, and I can't remember what setup needed to be put on the patient, but she did not do it correctly. Respiratory came up and, of course, came and got me and said, the student put on such and such of oxygen and it wasn't done correctly. The good thing is the patient suffered no ill effects, but it really was a learning lesson. And I told students from then on, you do not set up oxygen unless respiratory is there with you, because this could have been a serious situation in which the patient could have deteriorated because he was not getting the proper amount of oxygen delivered to him. But thank goodness he was stable. All right, let's look at these high flow type of oxygen therapy. This is probably one of the most familiar ones, a Venturi mask, where it delivers the most accurate O2 concentration, and we might also hear it called a venti mask. Okay, and here's a picture down here of a particular setup of a Venturi mask. And what we notice about this type of oxygen delivery system is there's little adapters that are connected that are color coded, and they usually say on there the percentage of oxygen that's going to be delivered. So look at that when you get report from your nurse to make sure if they're supposed to get 55% or 60% or 40%, that's exactly what's going to be delivered. Please note that when we have patients with respiratory problems, they get good, the patients get better, the patients get a little worse. We may be changing oxygen therapy throughout his hospital stay. Make sure we are providing our patients with what is ordered, what is the most current order for oxygen therapy, okay? You always want to verify it with your nurse, because maybe they're on cannula, and at one point the physician ordered 4 liters, at one point they ordered 3 liters. You want to make sure that what you're giving is what's the last and current order for that patient, okay? So just a little words to the wise, all right? Let's just go back to that regarding high flow. So we talked about Venturi mask. Face tent, this is a tent that fits over the chin. The top goes halfway across the face. Obviously, if we have patients that have burns, facial trauma, we're not going to put on a mask. How painful and ridiculous would that be? So we use face tents. Aerosol mask, high humidity. Usually after intubation, maybe a patient may have thick secretions. You can actually audibly hear that aerosol being delivered to your patient when you walk into the patient's room. Trach collar, we're going to talk about that. Remember these patients with trachs, because they're now having to breathe directly through that trach, and air is not going through the mouth or the nose. It loses its ability to warm and filter out the air. So we have to provide those means through humidity and kind of warming up that air before it actually goes into the lungs. So that's why patients with trachs will have trach collars. A T-piece is what we put on the end of an endotube, and I'll show you what that is. And what that does is, say for instance our patient's been on a ventilator, because they're on a ventilator that's connected to an endotube, maybe after some really very complex and long surgery. I know our patients who used to have coronary artery bypass would be on the ventilator overnight and connected to the ventilator. Well, we don't want them on a ventilator forever. They're able to breathe on their own when they start waking up from the anesthesia or whatever sedation we've given them. So we don't want to take this tube out yet. We want to make sure they're breathing well on their own. So we would check blood gases, and if they look pretty good, and we check our patient's tidal volume to make sure they're taking in a proper amount of air into their lungs, then we put them on a T-piece. And this also has oxygen, humidity, and we see how the patient does. Because now they're breathing on their own, okay? Because we've assessed, the patient respiratory-wise, we've looked at their tidal volume, we've looked at their blood gases. Then about an hour, we check blood gases again. And we can then extubate this patient, maybe put him on a mask or some specs, as long as everything continues to go well. But say, for instance, they're in a T-piece and we notice they're getting sluggish, their respiratory rate is diminishing. That's obviously a clue that they're not tolerating being off the ventilator, so maybe we have to put them back on the ventilator. Maybe there's some other issues going on that the patient's unable to fully breathe on his own. But if not, we can take him off the T-piece, extubate him, and get him on some kind of more reasonable oxygen therapy. So that's what a T-piece is, okay? Hopefully there's no questions about that. All right, now this next thing we're going to talk about is non-invasive positive pressure ventilation. And this is for patients that aren't intubated. We use techniques which uses positive pressure. And basically the bottom line is we're trying to keep that alveoli opened and improve gas exchange, that diffusion of gases, without actually intubating a person and putting them on mechanical ventilation. Okay, so that's basically what the objectives are when our patients are ordered either BiPAP or CPAP. You know, CPAP may be common. Sometimes we see our patients on these types of non-invasive ventilation equipment. Maybe one of the most familiar reasons are for sleep apnea. But CPAP and BiPAP. CPAP is applying continuous pressure to the airways, where BiPAP exerts high pressure when patient breathes in and delivers low pressure when they breathe out. So it involves inspiratory and expiratory pressures. BiPAP will help reduce the pressure when exhaled and increase the pressure when inhaled. That can't be adjusted when someone's on CPAP, okay? With CPAP, the person has to have or use more force for exhaling against the extra pressure. And this can be tiresome for patients who, especially for those that, you know, are sedated or have neuromuscular diseases. So that's kind of the difference between the two. CPAP only involves one pressure. It's kind of like the same as PEEP on a ventilator. So they have to actually exhale against the extra pressure. BiPAP will adjust that air pressure for it's easy to handle and adapts to a person that's using it. We use CPAP more for sleep apnea and BiPAP more for certain lung diseases like COPD. CPAP is much cheaper, obviously involving only one pressure, and usually the machines are a little bit larger, okay? So that's basically how they work. As I said before, CPAP is only one pressure, and it really increases that functional capacity of alveoli splinting, increases intrathoracic pressure, and it really has a cardiac effect where it decreases preload and decreases cardiac workload and increases, obviously, oxygenation, okay? So that's CPAP. All right, and then BiPAP is, you know, bi-level, sets two pressures, where your inspiratory positive airway is high pressure and your expiratory pressures are low pressures, okay? So I just thought, you know, I would just say it very simplistically, just to kind of give you an idea of what the bit of difference is between the two of them. Okay, so if you have any questions on that, just let me know. Here's a person on continuous positive pressure CPAP, and you can say, you know, it's not very attractive, but really sleep apnea is a very serious situation. And when patients get this equipment, which is very much covered by their insurance, they need to learn about the proper techniques of cleaning this equipment, because bacteria can begin to harbor in here. So there are certain, I wouldn't say detergents, but cleaning materials that are safe for the equipment, as well as killing off the germs that can harbor in this tubing to prevent that person from definitely inhaling those organisms and causing your patient to develop a respiratory infection. Okay, we can see a lot of these CPAP, BiPAP used for atelectasis, sometimes after cardiac surgery, pulmonary edema, holds open those lower airways and keeps them open. Okay, so that is CPAP and BiPAP. And then this other types of therapy called transtracheal oxygen delivery. It's used for long-term delivery of oxygen directly into the lungs. It avoids that irritation that nasal prongs cause and is more comfortable. And the flow rate is prescribed for rest and a different flow rate for activity. Usually what they use is a very small plastic tube. It's inserted into the lower neck, which leads into the trachea, and it bypasses the upper airways. So that's exactly what a transtracheal type of oxygen delivery is. Okay. The next thing I just want to talk a little bit about is home oxygen therapy. And there's a criteria for home oxygen therapy equipment. Usually the patient must have severe hypoxia or usually fall in the category of a classification of 5 for dyspnea. Usually their PaO2s are like usually 55 or below, and their pulse oxes are below 88 on room air and at rest. And those are usually the criteria they use, but obviously that can be a little bit give and take depending on how the patient presents. I don't need to go into this because obviously the oxygen that patients get at home is much more easier to handle, to carry around, so that patients who need oxygen can be more social and not have to stay at home because they're connected to an oxygen tank. I think if you go out to places like Cedar Point and the zoo, you'll see people with oxygen tanks that we didn't see before because, years ago those tanks were so big and cumbersome, it was really hard to carry them around. But now these patients have the ability to use these smaller tanks, which give them the freedom to come and go a little bit easier. Again, patient education, good teaching, safety issues, no smoking, what kind of container, are you using compressed air in a tank or cylinder, or do you have liquid oxygen in a reservoir, or do you have an oxygen concentrator? Again, review safety issues with both patient and with the family, okay? So that's oxygen therapy, okay? Sometimes we need to assess our patients while they're in the hospital and, do an evaluation of what their pulse ox is without oxygen when they walk in the hall. And we can document that, and that's another criteria that will be used to determine if the patients can go home on oxygen and whether or not it will be paid for by usually Medicare, okay? And that's oxygen therapy. Okay, the last thing we're going to talk about, and then I'll be done, is the tracheostomy, all right? The tracheostomy is the surgical incision into the trachea for the purpose of establishing an airway. And a tracheotomy is the surgical incision, and the tracheostomy is actually the stoma, or the opening that results from the procedure of a tracheotomy. You have to think about when you're assigned to a patient who has a tracheostomy, why did my patient have this? And is this a temporary or is this a permanent type of means of oxygenating our patients, okay? The thing is when, this is just a picture of the anatomy of the thyroid cartilage, the cricoid, the cartilage, and then this is usually where the cardiovascular surgeon makes that incision to the trach, usually around the 2nd, 3rd, and 4th tracheal rings, okay? If this is a planned tracheostomy due to some type of surgery that the patient needs to have. May, for instance, he has a laryngeal cancer or whatever, and we know that he's going to have a permanent tracheostomy when he goes into surgery. You might want to do a little pre-op care and pre-op teaching with these patients, because now we have the opportunity to tell the patient what to expect, okay? Because I'll tell you, when patients have a tracheostomy, it is really a big transformation for them, because it affects their bodily image, how they talk, how they communicate, how they eat, how they breathe. Everything changes, and it's a lot to take in. Okay, so we want to prepare our patient and teach us as much as we possibly can without them waking up and feeling scared and not knowing what to expect when now they have a tracheostomy, which now is their lifeline of how they breathe. They're going to have to bathe differently. Can they swim? Will they be able to take a shower? These are questions that a lot of these patients will have. Sometimes we're not so lucky that our patients have to have emergency type trachs because they might have a acute airway obstruction. So with that said, we don't always have time to prepare our patients for what to expect when they have a trach. Maybe they have some kind of laryngeal trauma. Maybe they've been involved in a car accident and have to have have an acute problem with their head, their neck, and we have to do some kind of trach on that patient. There's all kinds of things that we can tell our patient, but the one thing we want to make sure that we really emphasize is we want to ensure that our patient has a patent airway. Okay, that's the bottom line, just like with every patient without a trach. Possible complications, if it's not secure, it could actually decannulate, meaning that the trach come out. Is the tube obstructed? Now, we don't want a tube obstructed because this is their lifeline. This is how they breathe. And that obstruction can be due to, secretions. Did the tube get dislodged? A patient that we used to care for in intensive care was maybe a trauma patient, and we knew neurologically he was never going to be breathing on his own, and you can't have a patient with an endotube indefinitely. So these patients would be candidates for a permanent tracheostomy. Most of the trachs, and I'm going to show you a picture down the road, are sutured in. They do a chest x-ray to make sure everything looks good. And we'll kind of go over some of the nursing responsibilities with a patient with a trach, okay? These are some things that can happen, because think about where that physician is making that incision, and a pneumothorax could possibly happen, especially in the apex. That's why we look at a chest x-ray for placement are the lungs still inflated. Think about subcutaneous emphysema. Could actually have a tear in the trachea where air escapes, and that's where we get that crackling or that sub-Q emphysema. Bleeding. We expect a little bit of bleeding in the first day or so. Initially it's going to be bright red, but as time goes on, that should be turning much pinker to eventually no bleeding at all. But remember, if a patient bleeds, we don't want that blood going down in their trachea, because that's their lifeline, and our patients could end up with aspiration. Infection is a possibility, especially when people are not using sterile technique when they're suctioning a patient, because we want to keep that airway free of any organisms so they don't develop complications like bronchitis and pneumonia and things like that. Want to make sure to prevent infection, change dressings often. We'll go over parts of the trach. Tracheostomy tubes are mostly disposable now. We're even disposing of the inner cannula. We used to clean that with hydrogen peroxide, a diluted hydrogen peroxide, and then rinsing it with normal saline. But I think now hospitals are finding with evidence-based practice that still can cause infection, and Once we take that inner cannula out, we throw it away and put a brand new sterile inner cannula in. They can be cuff tube or tubes without a cuff for airway maintenance, and I'll show you what we mean by a cuff, inner cannula, disposable, reusable, or the fenestrated type. Okay. Some of the things that can happen, even though the equipment, the trachs are much safer on the trachea itself, but we still watch for signs of stenosis, fistulas developing, or even if someone begins to profusely bleed, the trach could have really put pressure on the innominate artery and caused this excessive bleeding. So those are things that we want to watch out for, okay? And this is what I was talking about. I'll be honest with you, this, as I point, is pretty much what your typical trach looks like. The Shiley trach is a company name that makes these trachs. They're disposable. They come in sizes because guess what? Everybody is not the same size. 7 is usually your standard size. And as you can see, this is inserted in the trachea. It kind of has a little curve to it, as you can see, and this is what we mean by cuff. And this is the little valve used to inflate and deflate the cuff and measure cuff pressure. So we would inject air into this, which would kind of blow this up. Why would we need a cuff? This kind of puts pressure on the trachea and kind of makes a seal so air doesn't escape, and we get a good seal to properly oxygenate our patients. This inner cannula can come out, and this is what I said we used to clean, and now we just throw it away and put a brand new one in. And this is what we call an obturator. And an obturator is kept in the bedside because, for instance, if this would come out due to a patient coughing, we could stick this in the stoma and hopefully keep that open, particular if our patients are having respiratory distress. Because remember, this is their means of, obtaining oxygen. Okay, so this is the cuff, as I said before, and I'm going to show you some of the cuff pressures or equipment that measures that pressure, because there should only be a certain amount of pressure, and respiratory therapy usually measures it about every 8 hours because we don't want it under deflated or over deflated, because too much can cause too much pressure on that trach and that very tender and sensitive mucosa. But if it's under deflated, we won't get a good seal. So those are things that we want to think about. Right here, the physician may put sutures through these little slats here, and this is also these little slots that's used for the trach ties. Okay, and if those get all gunky with a patient's secretions at first, especially if it's not sutured down, it's nice to have somebody in there to help you, because if the patient would kind of cough really violently, he could cough this actually out of his stoma. So it's nice if someone kind of holds this down. So this is a cuff inflated. This is the outer cannula. This is the balloon, the pilot balloon. This is the obturator. And like I said, this is the inner cannula. This kind of looks kind of like that. It kind of turns. You kind of turn it, or it's kind of like you're opening a jar, because there's a little notch that it fits in, and then this comes out. And this is what we call the disposable inner cannula. Sometimes these can get really full of a lot of secretions, and we don't want that to happen because this is your patient's airway. So we'll take that out and then throw it away, and then maybe we'll suction them before we put it back in, and then you've got a nice fresh sterile inner cannula back in the trach equipment. Okay. Over here is the fenestrated type of a trach, and as you notice from the picture here, I don't know if you could see that very well, fenestrations mean there's like little holes in that, and as you can see, it's a little bit of a wider type trach than this one here, the fenestrated should fit precisely. It should lie centrally in the airway. Otherwise, you have granulation of tissue will grow within the fenestrations, within these holes, having to have surgery to remove it, okay? This may be used on someone that we're trying to wean because we don't have a good seal anymore. Maybe the patient is doing much better respiratory-wise. Maybe we're going to keep the cuff deflated, and with the fenestrations, we can see that the patient can tolerate that pretty well. Again, it has an inner cannula, just like this type of trach, and then, of course, the obturator that we leave at the bedside. Okay, so that's the equipment. It's always good to have another box of the particular size that your patient has. So if we have to change the trach on our patients quickly, we've already got it there at the bedside. Okay, we only need one, but keep one in the box. So if we have to change this, maybe due to the patient has it dislodged. We had a trach one time that we couldn't suction down it, and it was actually kind of cannulated in the adjoining tissue. So they had to remove it, and then they inserted the trach, and then it was fine after that. These are care issues for the trach patient. Cuff pressure can cause mucosal ischemia. Use minimal leak technique and occlusive technique. Check pressure off, and usually they do it once every shift. I'm not sure if it's every 8 hours or every 12, but respiratory usually uses that. Make sure it fits stably, because you don't want it moving around in the trach, because you want to prevent tube friction and movement. Think about now, your patient has no means to eat, so we don't want them getting dehydrated or malnourished. We want to provide hemodynamic stability and definitely prevent hypoxia. Okay, this is kind of what they measure cuff pressure with, and we can see it in two methods of measurement, 14 to 20 millimeters of mercury or 20 to 28 centimeters of water, depending on what type of equipment we have to measure it with. Okay, so that's what usually RT does. Remember, the tracheostomy tube bypasses the nose and mouth, which normally humidifies, warms, and filters the air. Air must be humidified, maintain proper temperature, and ensure adequate hydration, because they can dry out very fast, their mucosa. So think about that. Okay, the one thing I want to talk about is suctioning, okay, because sometimes if a patient is unable, and that's the key, we don't want to suction if the patient is able to cough up the secretions, and really it depends on, does your patient have a lot of secretions? Sometimes it may not. Suctioning maintains the patent airway and promotes gas exchange. We only assess the need for suctioning from the patient who cannot adequately cough out their own secretion. We can suction through the nose or through the mouth, okay? And definitely in the trach. Remember, as we suction out secretions, we are also suctioning out oxygen. So we want to be careful that the following problems do not happen: hypoxia, tissue mucosal trauma, infection, vasovagal stimulation and bronchospasm, cardiac dysrhythmias from hypoxia caused by suctioning, suctioning too much, not doing proper oxygenation before and after, and we'll talk about that in a minute. But these can happen because, as I said before, you're suctioning out secretions, but you're also suctioning out oxygen. Okay. Causes of hypoxia: ineffective oxygenation before, during, and after. Maybe the catheter is too large, it's obstructing. Proper technique: we only suction when we're coming back out, not when we're going back in. Prolonged suctioning: you're staying in there too long, so my gosh, the patient's not able to ventilate and oxygenate. Excessive suction pressure: it should be on very low to medium pressure, and too frequent suctioning, okay, can also, because you're still sucking out all that oxygen, okay. These are complications: tissue trauma, infection, people aren't wearing sterile gloves, contamination, vasostimulation. If you notice that your patient's heart rate has changed, stop suctioning and immediately oxygenate your patient. Suctioning can also cause bronchospasm, so that may require respiratory to come up and do a stat treatment with a bronchodilator to kind of relieve that bronchospasm, because it's very scary when your patients experience that. I've had that happen to me a couple times. So what do we do to prevent this? So what we can do is make sure in your room when you have a patient with a trach that we want to be prepared for suctioning. So what we need is an ambu bag connected to the oxygen flow meter, and we turn it all the way up. So for instance, if your patient's conscious and they're breathing on your own, maybe in the beginning you'll want to do this with a partner. You take that ambu bag, you place it on the trach, and in synchrony with your patient's respirations, as they take a deep breath, you give your patient squeeze that ambu bag, give them a breath of 100% oxygen. Then you wait a minute, and then you do it again. Obviously, you don't squeeze the ambu bag when they're expiring, when they're breathing out. It's when they're breathing in. Now you've got a patient who's very, very well oxygenated, okay? So then we're ready for suctioning, and we suction, and obviously we only suction as we're coming out. And think about it, we only suction for 1 to 2 seconds. Think about yourself. How long can you hold your breath? Explain to your patient what you're going to do, because this can be very traumatic. You're putting a suction catheter down their trachea. So after you come out, you definitely assess how much secretions you got. Do you feel the need to go back in? If you do, or even if you don't, now after suctioning, you put the ambu bag back on the trach and give them 2 or 3 more breaths. Okay, so now you've re-oxygenated the patient, and this prevents a lot of these complications I just talked about. This should be done all the time. I find when I've done clinicals with students that the staff are not doing that. That's a chance they take. I will not allow a student to suction a patient with a trach unless they perform this before and after they suction. So I do ask the nurses if it's okay if we set up that particular equipment if we're going to suction a patient with a trach. If they don't want us to, then you guys as students, especially in my group, would not be able to suction, because I'm not going to risk the patients developing hypoxia and developing one of those complications, if not more than one, from sucking out not only secretions, but their oxygen. So that's the proper way, unless things are being done different because other new evidence has been shown. One thing I will say is if the patients have thick, tenacious secretions, and that's probably why they can't suction them out, do not squirt saline down their trach. It does nothing. It rolls off those thick secretions, and all you do is put a fluid down your patient's lungs, which is torture. It makes your patients cough. It gets them all rattled up. So I'll be honest with you, I used to do that maybe 20, 25 years ago. We don't do that anymore because evidence-based practice has shown that it's ineffective and it just hurts our patients, okay? Maybe they need an aerosol treatment or something like that to help bring up the secretions. So that's how we properly suction a patient: oxygenating before, suctioning, oxygenating off after. And do we need to go down again? Probably the most I suction somebody is twice. I like to get the rest of it the second time, and then I leave the patient alone and properly oxygenate them with the ambu bag. I stay there for a few minutes to make sure the patient's doing okay, that he isn't having some kind of vasovagal, heart rate's okay, his color looks good, and he's tolerated the suctioning okay. Assessment of the patient, securing the trach, make sure it's in place. If you have to change those ties, make sure that someone is there to securely hold down that trach so the patient doesn't cough it out. Remember, your patient is now a trach breather. He isn't taking in oral fluids, so he needs good oral hygiene as well as turning and repositioning. It's really good if we get the patient out of bed. And really this helps promote good pulmonary care, okay? Make sure your patients, you're not using glycerin swabs. And look into your patient's oral cavity. Assess for ulcers, bacterial or fungal growth. Do they have thrush? Is there lesions growing? Does his breath smell really very foul? We just want to check to make sure there's no secretions harboring in the back of the patient's throat or anything like that. You'll know if the patient has a respiratory infection because usually they get Pseudomonas, and when they cough, those secretions, it smells really bad. Nutrition, swallowing can be a major problem for the patient with a trach. If the balloon is inflated, it can interfere with the passage of food. So elevate the head of the bed for at least 30 minutes after the patient eats to prevent aspiration. Usually, initially, we don't feed the patient. We do have to assess that they're getting hydrated properly. Maybe they need tube feedings, whatever the case may be, but really be an advocate for this patient. We don't want them going days without food because they need calories to sustain muscle mass and to promote good health, okay? Remember, patients will have a communication problem if they can't communicate. Make sure they have a board nearby that they can write questions if they're conscious. Patients can speak with a cuffless tube, fenestrated tube, or cuff fenestrated tube that is either capped or covered. Make sure patients can write. If you have to ask questions in the beginning, make sure they're yes or no questions. Don't ask them something that they have to provide a 3-sentence litany because they can't talk. A one-way valve that fits over the tube and replaces the need for finger occlusion can be used to assist with speech. So that's another way. There's a lot of probably new techniques with our patients with trachs in which they can communicate better and talk and things like that. So we'll look that up. Weaning is a gradual decrease in the tube size and ultimate removal of the cuff. Cuff is deflated as soon as the patient can manage secretions and does not need assisted ventilation. Sometimes what they do is they'll take out the size 7 if that's what the patient had initially, and then they put in a smaller trach, maybe a 6 or a 5. If the patient does okay, then we can start weaning them and take it out, especially if it's a temporary trach. We can even put a cap on that trach with that patients can talk. Some of them can even start eating, and we just see how they do. Just make sure that our patients are safe when they eat with a trach so there's no chance of aspirating, okay? And that pretty much concludes that chapter on O2 therapy and tracheostomy. I'm going to conclude now. After you view this lecture and listen to what I had to say, feel free to ask me any questions either through Thursday or just bring your questions to class and we can talk about those in class if there's something that isn't clear or something you didn't quite understand. I appreciate your attention, and then our lecture will start on the next chapter, okay? So thank you for your time, and I hope you have a great night and a great day.